And I want to begin by talking about some of the different regions of the rectum as well as the anal canal. And then we'll spend some time talking about the pectinate line, which is probably the most important uh, and heavily tested concept in the entire rectum section, whether it's anatomy, physiology, or conditions. So there's 5 regions I want you to know about. The first we've talked about before in the large intestine lecture. This is the rectosigmoid junction, and I've highlighted it to the picture to the right. The reason why the rectosigmoid junction is important is because it's a watershed region. And so watershed regions, as a reminder, are regions at the very end of your blood supply. And because they're at the very end and they have the least amount of perfusion, they are the most they're the regions that are most at risk in the setting of systemic hypotension, like shock. In the large intestine, you need to know 2 different watershed regions. There is the splenic flexure, also known as Griffith's point, and there's also the rectosigmoid junction, which we're talking about now. And I have in the picture here, you can see how when the blood supply comes directly off of the superior mesenteric artery or the inferior mesenteric artery, there's very, very high perfusion pressures. But as the blood supply starts to go more distal, you're going to lose that blood supply. And if you ever have a situation where systemically this perfusion is not very good, you can see how this could easily cause a problem in either this region or in the rectosigmoid junction. And ischemic colitis is the disease that typifies this pathogenesis we just talked about. And again, we have our rectosigmoid junction highlighted here. And so more distally to the rectosigmoid junction, you'll have your rectum. And what I'll do is I'll change it to a slide where we can see everything. So here's our rectum I've circled. You have your upper anal canal. You can see the lower anal canal. And dividing the upper and lower anal canal is something called the pectinate line. And as I alluded to, the pectinate line is probably the most important thing that you need to be aware of when you're studying this section. This line divides your endoderm and your ectoderm. And so what does that mean? So remember, when you look at embryologically how our GI tract is forming, we have our embryologic foregut, midgut, and hindgut. And the pectinate line will help divide this hindgut from a different type of tissue. So here's our hindgut I've circled, which will have our rectum and our upper anal canal. Keep in mind, though, that we have other tissue that's not technically part of our embryologic GI tract that needs to connect here. And this will comprise our lower anal canal. And this line right here that divides these 2 different embryologic regions is known as our pectinate line. This is from our GI tract introduction lecture, where I talk about the foregut, midgut, and hindgut. And notice here that in the hindgut, we mentioned that the rectum is involved, but I also told you that some parts of the GI tract, like the lower anal canal, are not technically part of the embryologic GI tract. And we've seen this earlier in our lecture series when we talked about the esophagus, how the proximal half of the proximal 2/3 of the esophagus is made up of different type of tissue, namely that non-keratinized stratified squamous epithelium. And whereas the distal esophagus, as you can see here, was comprised of glandular tissue like columnar cells. And that's because that was part of our our embryologic GI tract in the foregut. The same thing's happening here, where our rectum and our upper anal canal is a part of our hindgut. So it's going to receive a distinct nerve supply, lymphatics, and all that. Whereas distal to the pectinate line will have a different epithelial composition. And let's go over all of that now. And again, just as I was saying, the tissues above and below the pectinate line are going to have unique origins. And so therefore they'll have unique blood supply, lymphatics, innervation, and some clinical conditions. So let's break this down in a chart. So when we talk about the artery that's going to supply the region above the pectinate line, it's going to be the superior rectal artery, which is a branch off of the inferior mesenteric artery. Now, the inferior mesenteric artery should not surprise you, because remember when we were talking about the foregut, midgut, and hindgut, whenever we talk about the hindgut, the artery supplied was always the inferior mesenteric artery, and this is no exception. On the other hand, if you look at the region below the pectinate line, such as the upper anal canal, that region is going to be supplied by inferior and middle rectal arteries. And those arteries are not branch points off of the IMA. Instead, they are branch points off of your internal iliacs and your internal pudendal arteries. So let me show you the difference in this diagram to the right here. So if we look at above the pectinate line, so remember this is part of our hindgut, and because it's part of our hindgut, you're going to start, the blood will start from the inferior mesenteric artery and ultimately reach this superior rectal artery. On the other hand, for the regions that are below the pectinate line, these regions will be supplied by your internal iliac artery and followed by your internal pudendal artery before reaching either the inferior rectal artery or the middle rectal artery. And notice the middle rectal artery can sometimes branch directly off of the internal iliac. But the point I'm making here is that above the pectinate line, it's always going to be a hindgut organ, so it's going to be supplied by the IMA, and below the pectinate line, it's going to be through an entirely different blood supply pathway. So when we talk about the venous drainage of these regions, they're going to essentially take the same route they came in. So what do I mean by that? Well, we just saw how the artery came from the IMA into the superior rectal artery. So in this case, we're going to go out from the superior rectal vein to the inferior mesenteric vein. And what I want to mention is that the inferior mesenteric vein is attached to your portal system. So that will drain into the splenic vein and ultimately your portal vein. On the other hand, if you look at the veins below your pectinate line, you're going to have your inferior or middle rectal veins draining into your internal pudendal vein, which will drain into your internal iliac, your common iliac, and your IVC. And again, this is the exact same route in reverse. If instead of the IVC, we think about the aorta, which would drain into your common iliac artery, your internal iliac artery, internal pudendal, and finally your internal rectal. So your inferior rectal, excuse me. So these all are just the reverse of what the arterial supply just did. So let's talk about those in a diagram again. And I'm going to use the exact same diagram. We're just going to assume that these are now veins to make it easier for you guys. So let's talk about what happens above the pectinate line. So you're going to have your superior rectal vein, which will drain into your inferior mesenteric vein. And the only caveat here, the only difference is that because you're part of your embryologic GI tract, it's going to drain through that special portal system. So what does that look like? Again, you have your superior rectal vein draining into your inferior mesenteric vein. And as part of the portal system, that will all drain into the splenic vein. And finally, it'll reach the portal vein where it can be metabolized by the liver. It'll go through our central vein into our hepatic veins, and then finally reach our IVC. Like we're going to see this many times when we look at the liver section coming up later on. On the contrary, if you have tissue that's below the pectinate line, the veins will drain through the inferior or middle rectal veins. In the case of the inferior rectal vein, it would drain into the internal pudendal, then the internal iliac, the common iliac vein, and then the IVC. And notice I'm just using the arterial supply to just show that the venous equivalent to that would be the drainage, to make it easy for you to understand. That way you only have to learn one pathway, whether it's the artery or the vein, and then you can just reverse it conceptually and you'll know the pathway. Now for these next four features of the pectinate line, it's a little bit easier to remember it with this mnemonic. And the mnemonic that I think about when I go through this is that when you consider the area that's below the pectinate line, such as your lower anal canal, what's going to happen is that that area is closest to the surface. It's closest to the outlet. And so when I think about the lymphatics, the innervation, the cancer subtype, and the type of hemorrhoid, when I'm thinking about which is which, I always think about which of the named features sounds closest to the surface. And so let me explain what I'm talking about as we go through this. So for the lymphatic blood supply, if you're above the pectinate line, you're pretty far away from the surface. So those tissues are going to drain to the internal iliac lymph nodes. On the other hand, if you're below the pectinate line, those regions drain to superficial inguinal lymph nodes. And again, if you think about the name internal versus superficial, it's pretty obvious which of these two sounds like they're closest to the surface. So the superficial lymph nodes, to me, sound closest to the surface. If we talk about innervation, if you're above the pectinate line, it's going to be innervated through visceral innervation, whereas below will be innervated with somatic innervation. And again, the difference between visceral and somatic, if we go back to our GI intro lecture, where I talk about intraperitoneal versus retroperitoneal organs, I discuss these differences. And the visceral peritoneum was this region right here that I've highlighted in purple that surrounds the organ directly. And it has the same autonomic nerve supply as organs. On the other hand, the parietal peritoneum surrounds the abdominal cavity. So it surrounds all around here. And it has somatic nerve supply. And so when I think of visceral innervation versus somatic innervation, you can see how these somatic nerves are generally much closer to the surface compared to visceral innervation. So when we talk about the different types of cancers, if you look above the pectinate line, you'll see adenocarcinoma predominate, whereas below the pectinate line, you'll see squamous cell carcinoma. And this is the same thing we saw in the esophagus lecture, where the region that was closest to the oral cavity and outside of the GI tract we'd see squamous cell carcinoma, whereas we delve deeper inside of the GI tract, essentially further away from the surface, we started to see adenocarcinoma because those cancers were arising from tissues that were a part of our embryologic GI tract. And again, here's our GI tract subdivisions that I've shown you a few times now. We have our foregut, midgut, and hindgut, but we definitely had regions here that were not part of our embryonic GI tract. And all these regions are prone to the squamous cell carcinoma instead of that adenocarcinoma. And when we look at what type of hemorrhoids are going to form in each of these regions, above the pectinate line, you're going to get internal hemorrhoids, whereas below the pectinate line, you're going to have external hemorrhoids. And again, the name kind of speaks for itself. An external hemorrhoid sounds much closer to the surface. And that's why I like this mnemonic, because it holds true for each of these four. And then these two things, you can just, like I said, as long as you remember one of the pathways, let's say the arterial supplies for both of these, you'll know the venous supply is essentially just the reverse. And you just have to switch most of the time, you just have to switch the artery to the venous equivalent. So let's move on to physiology. This will be our shortest physiology section by far. I just want you to know that the rectum and anal canal has some responsibility with electrolyte absorption, and then obviously it's useful for stool excretion. There's nothing really step 1 or level 1 is going to test you on that you generally need to know about rectal and anal canal physiology. They really like to emphasize the anatomical relationships, especially with that pectinate line that we talked about more. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.